Hello and welcome back to iSpy. Today we are going to talk about binocular balancing, one of the most important steps in giving patients clear and comfortable binocular vision. In this video, we'll cover what binocular balancing is, why it's important, the preconditions before performing it, the different types of binocular balancing with explanations of some key methods, how to calculate the final prescription, and finally, situations when binocular balancing should not be performed. So let's start with the basics. What exactly is binocular balancing and why do we need it in clinical practice? So after we complete the monocular subjective refraction for each eye individually, the next important step is binocular balancing. But what exactly does that mean? Binocular balancing is simply the process of equalizing the accommodative demand between the two eyes. In other words, it makes sure that both eyes are working equally together and that one eye is not putting more effort than the other. Now let's see why we actually need binocular balancing in clinical practice. For example, you have just completed a refraction. Both eyes are reading 6:6 perfectly, but the patient still says, Doctor, my vision is clear, but I feel eye strain and headaches after reading. This usually happens when one eye is slightly overcorrected or undercorrected compared to the other. As a result, the patient may complain of eye strain, headaches, difficulty in reading, or even suppression, where the brain starts to ignore input from one eye. That's why binocular balancing is so important. It ensures comfort, not just clarity. In short, the purpose of binocular balancing is to achieve comfortable, balanced vision, reduce eye strain, improve binocular visual performance, prevent latent hyperopia or over minus correction. Now let's talk about when to do binocular balancing and the preconditions you need to check before performing it. So binocular balancing is performed after monocular subjective refraction for each eye, including best sphere and best visual acuity. Then duochrome test if used, then cylinder refinement if there is any astigmatism, and finally fogging control for accommodation. But remember, there is also one very important precondition. Binocular balancing should only be done if both eyes have relatively equal visual acuity, usually within the one line on the chart. If one eye has significantly reduced vision compared to the other, balancing is not recommended. Now let's move on to the different methods of binocular balancing. There are many available in the books, but in clinical practice, three are most commonly used are alternate occlusion, prism dissociation, and Borish'S delayed method. But remember, the goal of each method is the same, to make sure both eyes are accommodating equally after refraction. So let's start with alternate occlusion method. Let's see procedure step by step. Step 1 is setup, in which we ask patient to look at the distance chart with both eyes open, wearing their best monocular correction. For example, right eye needs -2 diopter spherical with -0.5 diopter cylinder at 180, and the left eye needs -2.25 diopter spherical with -0.5 diopter cylinder at 180, and both eyes can see 6:6 individually. Step 2 is fogging, in which we gradually increase the plus power in front of both eyes in +0.25 diopter spherical steps. The aim here is to blur the vision by about 1 or 2 lines above the best corrected visual acuity. So for example, we keep adding +0.25 lenses until the patient can read the 612 line, but the lines below that appear blurred. This controlled binocular fogging relaxes accommodation and sets the stage for accurate balancing. Now suppose after fogging with +1, patient is saying that 612 line is readable and after that all lines are blurred. Next step is balancing with alternate occlusion method. So use cover pedal to cover both eyes one by one and back and forth in a consistent manner, and ask the patient that letters of 612 line are clearer with right eye or left eye. Now suppose patient is saying that right eye image is clearer. Then add plus 0.25 before right eye. And again perform alternate occlusion to ask if both eyes are equally blurred or one eye is still clear. And patient says that right eye is still clear than left. Then again add plus 0.25 diopter before right eye. And again repeat the alternate occlusion until both eyes are equally blurred. And when patient says that both eyes are equally blurred, that indicates balanced accommodation in both eyes. Step 4 is defogging. Here we reduce the fogging lenses binocularly in plus 0.25 diopter steps until the patient can comfortably read the 6-6 line. But the key point is don't remove all the fogging lens all at once. For example, as we have added plus 1 diopter as the fogging lens. So to defog, first place 0.75 diopter, then remove plus 1 and ask the patient up to which line can you read now, and repeat this process by reducing in 0.25 diopter steps. Suppose patient still cannot read 6th line, then place 0.5 diopter, then remove 0.75 and ask patient up to which line can you read now. And after switching from 0.75 to zero point 0.5 diopter, the patient reports that 6th line is readable. Then the defogging is complete. Step 5 is calculating final prescription. So the initial power was minus 2 diopter with minus 0.5 diopter cylinder at 180 in right eye and minus 2.25 diopter spherical with minus 0.5 diopter cylindrical at 180 in left eye. Then we added plus 1 as the fogging lens binocularly. Then an extra plus 0.5 diopter added to the right eye for balancing. Then during defogging, plus 0.5 diopter spherical removed from both eyes. So the final prescription becomes minus 1 diopter spherical with minus 0.5 diopter cylindrical at 180 in right eye and minus 1.75 diopter spherical with minus 0.5 cylinder at 180 in left eye. So this shows that right eye was overcorrected by minus 1 diopter spherical and left eye was overcorrected by minus 0.5 diopter spherical power before balancing. This is how to perform alternate occlusion method of binocular balancing, which looks simple, right? But here is the catch. This technique has several issues. Limitations of alternate occlusion. Patients often compare the current view with what they saw a moment ago, so memory can affect the accuracy. Then timing matters. If the pedal is moved too slowly, each eye may accommodate differently. In case of too fast, the patient cannot keep track of which eye is being tested. And the first uncovered eye sets the accommodation tone, so the results can be biased. So in summary, the alternate occlusion method is quick, simple and only needs a pedal, but in practice it can be misleading. Now let's move on to the second method of binocular balancing, the prism dissociation method. This is one of the most commonly used method in clinical practice because it minimizes patient memory bias and gives more accurate results compared to alternate occlusion. The goal is the same, to ensure both eyes are accommodating equally after refraction. Let's see procedure of prism dissociation method step by step. In step 1, we ask patient to look at the distance chart with both eyes open, wearing their best monocular correction. For example, right eye needs minus 2 diopter spherical with minus 0.5 diopter cylindrical at 180, and in the left eye needs minus 2.25 diopter spherical with minus 0.5 diopter cylindrical at 180, and both eye can see 6 individually. Step 2 is fogging, in which we gradually increase the plus power in front of both eyes in plus 0.25 diopter steps. The aim here is to blur the vision by about 1 or 2 lines above the best corrected visual acuity. So for example, we keep adding plus 0.25 diopter lenses until the patient can read 612 lines, but the lines below that appear blurred. This controlled binocular balancing relaxes accommodation and sets the stage for accurate balancing. Now suppose after fogging with plus 1 diopter spherical, patient is saying that 612 line is readable, and after that all lines are blurred. Step 3 is adding prisms to separate the images seen by each eye. Typically, 4 prism diopter base down is placed in front of the right eye and 4 prism diopters base up in front of the left eye. Now we show the patient a single line of 612 letters, and because of the prism's optical property, the patient will see two lines of 612 letters, one above the other. So as we know that image deviates towards the apex of the prism, so the upper image comes from the right eye as apex is up in the right eye, and the lower image comes from the left eye as apex is down in the left eye. Now step 4 is balancing, which we start by asking the patient that which row of letters is clearer as compared to the other, the upper one or the lower one, and add plus 0.25 diopter spherical to the clearer target until patient reports that both the images are equally blurred. Now suppose patient is saying that the upper image is clearer and we know that upper image belongs to the right eye, so we will add plus 0.25 diopter spherical to the right eye. We ask again, now which image looks clearer? And patient is saying that upper images is still clearer. Then we add another 0.25 to the right eye. And now patient is saying that both the upper and lower images are equally blurred, which indicates balanced accommodation between both eyes. And in total we added plus zero point 0.5 diopter to the right eye. Once balancing is complete, we remove the prisms. Step 5 is defogging. Here we reduce the fogging lenses binocularly in plus 0.25 diopter spherical steps until the patient can comfortably read the 6-6 line. But the key point is don't remove all the fogging lens at once. For example, as we had added plus 1 diopter spherical as the fogging lens. So to defog, first place 0.75 diopter spherical, then remove plus 1 and ask the patient up to which line can you read now, and repeat this process by reducing in 0.25 diopter steps. Now suppose patient still cannot read the 6-6 line, then first place 0.5 diopter spherical, then remove 0.75 diopter spherical, and again ask the patient up to which line can you read now, and after switching from 0.75 to zero point 0.5 diopter, the patient reports that 6-6 line is readable, then defogging is complete. Step 6 is calculating final prescription. So initial power was minus 2 diopter spherical with minus 0.5 diopter cylindrical at 180 in right eye, and minus 2.25 diopter spherical with minus 0.5 diopter cylindrical at 180 in left eye. Then we added plus 1 diopter spherical as the fogging lens binocularly. Then an extra zero point 0.5 diopter spherical we added in the right eye for balancing. Then during defogging, plus zero point 0.5 diopter spherical removed from both eyes. So the final prescription becomes minus 1 with zero point 0.5 diopter spherical at 180 in the right eye, and minus 1.75 with minus zero point 0.5 diopter spherical at 180 in the left eye. So this shows that right eye was overcorrected by minus 1 diopter spherical and the left eye was overcorrected by minus zero point 0.5 diopter spherical power before balancing. And that completes the prism dissociation method of binocular balancing. Now let's see why prism dissociation method is more reliable than alternate occlusion method. Because the images are separated vertically, so the patient directly compares them. There is less chance of memory bias and it's easy for the patient to understand and respond. So in overall, this is preferred method for precise binocular balancing in clinical practice because it gives more consistent and objective results. Now let's move on to the third technique of binocular balancing, Borish's delayed balancing method. This method helps us to achieve maximum relaxation of accommodation without using cycloplegics. Let's see procedure step by step. In step 1, we ask patient to look at the distance chart with both eyes open, wearing their either the retinoscopic power, autorefractometer power, or their most recent glasses power, whichever is available. For example, after retinoscopy refraction, is -2 diopter spherical with -0.5 diopter cylindrical at 180 in right eye and -2.25 diopter spherical with -0.5 diopter cylindrical at 180 in left eye. Step 2 is fogging. For fogging, we perform NRA, the negative relative accommodation. For those who don't know about NRA PRA and want a detailed video, let me know in the comments. I'll make a separate video on that. For now, let's see how to perform NRA. So for this, we ask patient to fixate at a near target at 40 centimeter distance, one line below their best visual acuity. If N6 is the best visual acuity, then use N8 as the target. Then add plus power in 0.25 diopter spherical steps binocularly until the patient reports first sustained blur. Sustained blur is when even with efforts, the patient cannot clear the letters. But remember, add the next plus lens before removing the previous one. Suppose with +3 diopter spherical, patient reports sustained blur. So the NRA value is +3 diopter spherical and the normal expected NRA is +0.25 diopter spherical. So the +3 diopter indicates overcorrection here. Now next step is balancing, in which we ask patient to fixate at a distance chart. Now because the fogging lens power is high, so the patient's vision may drop to 636 or 660. Suppose in this case patient can read only 636 letters. So for balancing you can use either the alternate occlusion or prism dissociation, whichever you feel convenient. I prefer prism dissociation method because it is more reliable. So add two prism, four prism diopter base down in front of the right eye and four prism diopters base up in front of the left eye. After this, patient will now see two lines of 636 letters. And now ask patient which is clearer, upper or the lower image. And add +0.25 diopter spherical to the clearer eye until both images are equally blurred. Suppose patient says that the lower image is clearer and we know that the lower image belongs to the left eye. So we will add +0.25 diopter spherical to the left eye. And we ask again, now which image looks clearer? After rechecking, patient reports that both upper and lower images are equally blurred, which indicates balanced accommodation between both eyes. Once balancing is complete, we remove the prisms. And in the next step of defogging, we reduce the fogging lenses binocularly in +0.25 diopter steps until the patient can comfortably read the 6-6 line. But remember, don't remove all the fogging lens at once. Follow the same step-by-step method as we did in the other techniques. For example, fogging lens is +3 diopter spherical. So to defog, first place 2.75 diopter spherical, then remove +3 and ask up to which line can you read now. Repeat this in +0.25 diopter spherical steps. Suppose the patient reports that with 0.75 diopter spherical, they can read the 6-6 line. So defogging is complete. Step 6 is calculating final prescription. So initial power was -2 diopter spherical with -0.5 diopter cylinder at 180 in right eye and -2.25 diopter spherical with -0.5 diopter cylinder at 180 in left eye. Then during fogging we added +3 diopter spherical binocularly and in balancing we added an extra 0.25 diopter spherical to the left eye. Then finally, during defogging, +2.25 diopter was removed from both eyes. So the final prescription becomes -1.25 diopter with 0.5 diopter cylinder at 180 in right eye and -1.25 diopter spherical with -0.5 diopter cylinder at 180 in left eye. This shows us that before balancing, right eye was overcorrected by -0.75 diopter spherical and the left eye was overcorrected by -1 diopter spherical. And with this completes the Borish delayed method of binocular balancing. Now that we have seen the three major methods of binocular balancing, alternate occlusion, prism dissociation and Borish delayed method. Let's talk about some important clinical situations where binocular balancing should not be performed. So, if one eye's visual acuity is significantly worse, say 6:6 in one eye and 6:12 in the other, the patient cannot judge clarity equally. Balancing in this case will not provide reliable results. Then, in patients with suppression or manifest strabismus, fusion is disrupted. Since balancing depends on the comparing both retinal images, it cannot be performed accurately. If the patient cannot maintain the stable accommodation, for example, in very young children, fatigued or anxious patients, responses during fogging and balancing will be unreliable. In cases of high anisometropia or ocular pathology, the blur sensitivity between eyes differs. So equal blur doesn't truly represent equal accommodation. And obviously, if the patient has vision in only one eye, binocular balancing cannot be done since the process depends on the simultaneous comparison between two retinal images. So, in summary, binocular balancing is a valuable step for accurate refraction, but it should only be done when both eyes have stable, equal, and functional vision. If you have any questions, drop them in the comments below. I'll be happy to help you. Don't forget to like, share, comment, and subscribe to iSpy for more eye care knowledge booster videos. Thank you for watching, and I'll see you in the next video.